So Pauline, welcome to the DLD project. Pauline is the first author of a new paper, a systematic review and narrative synthesis looking at intervention dosage for children with DLD. So Pauline, welcome. Can you tell us a bit about what your paper is about?
Yes, the paper is about the concept of dosage really in the context of speech and language therapy. So we think of dosage as a pharmacological concept, like that's when we're very familiar with it in terms of giving Calpol to a little child. We know that we should give 5 milligrams and we know we give it 4 to 6 hour intervals. So we know the dose and we know the dose frequency. But when it comes to intervention studies that are behavioral, it becomes a much more complex concept to describe and then consequently to measure. So that's what this paper is about. It's about applying those concepts to speech and language therapy. And in 2007, Stephen Warren put out five actually, dosage characteristics that we should use to describe intervention intensity. And the first one was what we call dose form, which refers to the qualitative aspect of dosage. So that's less the focus of this paper, but it's the tasks or activities within which the teaching episodes are delivered. So then there are 4 other concepts that he put forward. So one is dose, which is the number of properly administered teaching episodes within a given session. And then we also have dose frequency, which is the number of intervention sessions per unit time. So it could be per day or it could be per week or whatever. Then we have the total intervention duration, which is of course the length of time that the intervention takes place. And then we have this concept of cumulative intervention intensity, where we multiply the dose by the dose frequency by the total intervention duration. So they're the sort of key concepts. So what we wanted to do is have a look and see if we could do a systematic review on papers in which those 4 quantitative measures of dose were either statistically or experimentally manipulated in interventions for children with developmental language disorder. And we wanted to do it across domains. So we wanted to include phonology, vocabulary, and morphosyntax. And the reason that we did that is we wanted to see were there differences across the domains and what kind of gaps were in the literature, as well. So obviously as well, the reason we did this is because speech and language therapy comes with a cost, and we want to know if, we want to determine whether more is always better, whether does an increase in dose always lead to better outcomes, and is there a baseline dosage below which there's no effect or minimal effect. So that was kind of the motivation behind doing the review, and that's what it's about.
It sounds fantastically useful, particularly from a clinical perspective, but also potentially families who are thinking about how often they should be able to see this speech pathologist. Pauline, what are some of your key findings from the systematic review?
Well, unfortunately, probably the dominant key finding is the lack of intervention studies across domains in which these aspects of dosage have been manipulated or statistically, either statistically or experimentally. So that's kind of, I suppose, the first key finding. There were only about 13 papers in that we ended up including in the review. So we're working from quite a small research base, really, and this work is relatively really in its infancy. There were no articles that reported on phonological outcomes, only 3 on vocabulary and about 8 on morphosyntax. And then we had a couple with omnibus kind of mixed outcomes, if you like. Now, I suppose when I say there are none on phonology, I do think it's important that we acknowledge the work that's been done in speech sound disorder, and possibly some of that work could be applied to developmental language disorder. But I guess given the kind of meta-linguistic components of a lot of phonological interventions, we would need to test that to see if that really is the case. So that was one of the core key findings. Then also a number of studies included in the review had quite small sample sizes. So that was, a bit disappointing in terms of trying to extrapolate. But in terms of sort of thinking about clinical things that we can draw on, more, I guess, is not always better. That's one of the core key findings, because we do, I suppose, intuitively, we think that more will be better, but more is not always better, both from the point of view of vocabulary in terms of the number of exposures, but also in relation to morphosyntax in terms of the frequency of intervention sessions. So we didn't find. So we get these diminishing returns after a period of time. So there was some very nice work done just in relation to vocabulary by Holly Storkel, where they found 36 exposures was optimal. But when we went to 48, you start getting a diminishing response. So that's a really important finding, I think, from the point of view of a clinician. There's also some evidence suggesting that younger children may be able to require fewer sessions to get the same results. But again, I suppose we would need these findings to be replicated more, and dose frequency and the total intervention duration wasn't accounted for in that finding. And also, of course, there's the impact of the dose form, so the actual teaching activities. That has a massive influence, of course, on the dose, because there's an interaction between one and the other. Our findings also suggested that that if the dose is high, that we could possibly reduce the frequency of the dose sessions, of the number of sessions. So particularly for morphosyntax. And also, interestingly, we found that when other aspects of dosage were controlled, there wasn't any learning advantage for spaced versus masked. So, a lot of the literature would suggest that there's an advantage there for spaced over masked between sessions, between session spacing. But we didn't find that. We found that when all other aspects of dosage were controlled for, that there wasn't any advantage. But then it was quite problematic because how spaced and masked are defined varies so much. One person's masked is another person's spaced. So you can't, it made cross-study comparisons really difficult. Mm-hmm. But one of the areas that I found really interesting, and it's just starting to be more researched, is this concept of within session spacing. So, and this is where the dose really comes into its own, I think. And so Elena Plant did a very nice study where they manipulated the number of doses within the session. So I can't remember the exact number, but say 15 doses in 15 minutes versus 15 doses in 30 minutes. And there was no difference in the treatment effect. So I think that's a huge piece of information for clinicians, if that finding is to be replicated, that you could achieve the same result by keeping the dose high over a shorter period of time. But again, that was that was a preliminary study they had done, and the sample size was quite small. So we need to see that finding replicated a few times. So they're kind of, they're some of the core key findings. There is a need to better understand the kind of interaction between, child level factors and dosage, and also the interaction between the quantitative aspects of dosage and the qualitative aspect, because there is some evidence not reported in this review, but when we also looked at dose form, and there is some evidence coming out suggesting that if we increase the variability within the dose form, we can reduce the number of doses. So it's an interesting area. I think that there's a lot of scope for research and a lot of, there are implications for clinicians, but I think we just have to be a little bit careful because we need more application.
Yeah, so it sounds like there's a bit of a call out for researchers to be looking more astutely at interventions, as well as making sure that we're replicating some of those existing findings.
I think we have to, from an experimental point of view, we have to really try to control one aspect of dose at a time, or manipulate rather one aspect of dosage. Because if we're talking about manipulating dose, for example, but if total intervention duration is not controlled for, then we end up with a confound. Sorry, I interrupted you, Sean.
No, don't apologise at all. What I was going to then say was, you've mentioned some implications for clinicians, but are there any other things that you think clinicians might find really helpful that they could apply, or perhaps even some of our families who might be listening in?
I think the evidence is quite limited for clinicians to draw on, especially if you're to talk to managers and policymakers and to try and change practice. But I think the concept of dose is huge. And I think that, previously we had this proxy measure. The dose was how many sessions you had and how long were they. That was kind of the proxy measure. Whereas I think this idea of being aware of the number of properly administered, in inverted commas, teaching episodes that we have within a session. So if it's word exposures, how many word exposures were there? Because, what we do in a half an hour of a session, we all know we could spend 15 minutes talking to a parent who came stressed and was late. And, so it's what you do within that session. I think we need to be much more nuanced about that. That would be one thing. And the other thing is, how do we measure learning and success? I think that would be the other thing I'd really try to ask clinicians to think about more, and researchers to think about more, is, what are the outcomes that we're using? Because if you're measuring word learning based on naming, or measuring word learning based on giving a definition of a word. They're they're poles apart in terms of what a child has to do. And so what the outcome measure is, how do we measure the success to know whether, yes, we're saying, yes, the child knows that now. And the other thing is the timing of those, because I really think in clinical practice, we don't tend to bring people back 6 weeks later to see if they maintained their learning. Once, certainly in Ireland, we're forced from an economic point of view to see people in 6-week blocks, and then the block is finished. But we're not looking at the maintenance levels of the learning, and the research is suggesting that that has a really significant impact. I mean, even 1 and 2 week post intervention, we see a 40% drop of word learning on what the outcome was directly post intervention. So I think those outcome measures are so important. And I think that's something that clinicians are probably not, we're not always trained to think about in that way.
Now, I realise your paper is available, but not everybody will be able to access it. Would you be happy, Pauline, if people reached out and contacted you if they wanted to learn more or access your paper?
Absolutely, absolutely.